second part is your removable partial denture. Basics in that, first we'll see a few terminologies and then we'll go into details. A removable partial denture or RPD is a removable denture that replaces some teeth in a partially edentulous arch. The removable partial denture can be readily inserted and removed from the mouth by the patient. As the name suggests, removable, so easily inserted and removable by patient. Partial, it's not complete, so some missing teeth are there and few natural teeth are present in this. Now, whenever you see any partially edentulous condition, try to restore with a fixed prosthodontics. Why? Because it will help in a better maintenance of the health and function for the patient. Direct forces will fall along the long axis of the tooth, and psychologically it's always easier for the patient not to remove the dentures and again wear it back. They will think the fix is a part of them only. But not all the conditions are possible for a fixed partial denture, FPDs. There are certain valid indication for removable partial denture. Some of them are like at a very young or an advanced age. Greater length of edentulous span is there. Excessive loss of the bone in edentulous area. No abutment teeth posterior to edentulous space, that we call as distal extension cases. Reduced periodontal support of the remaining teeth. When there is a need of cross arch stabilization, patient is undergoing physical or emotional problem. Aesthetic is primary concern in replacement of missing multiple teeth. Need to replace them immediately after extraction. That is transitional till the time it heals and whenever the patient desire because of its financial or time constraint. Certain contraindication for removable partial denture: large torics, large tongue, unfavorable attitude of the patient, unfavorable gag reflex, muscular incoordination of the patient, and patient who can't maintain proper oral hygiene. Now, when we talk of partial edentulous cases, unlike complete denture, you don't have a teeth, it's easy to communicate. But when it happens so that your few teeth are there and few are missing, and you want to plan, design a treatment and execute it, it becomes very difficult to coordinate with somebody else. So in that case, you require a classification, which when you tell over to somebody, they should be easily able to visualize that condition. They should be differentiate easily between whether it is a tooth supported or a tissue supported. It should help that classification to formulate a design for the processes, and it should be universally accepted. I'll tell you, there are tons of classification given for partial denture. Still, Kennedy's classification holds very good, and you should all know regarding Kennedy's classification and Applegate's rule. So I will not going to summarize various classification like Evans, Cummers, Skinners, n number of they are there. I am just going to focus on your Kennedy's classification, Applegate rules, and components of removable partial denture. So Dr. Edward Kennedy in 1923, based on the partially edentulous arches, he gave 4 classes of Kennedy's situation. First is class 1, which is a bilateral edentulous area located posterior to remaining natural teeth. So these are the natural teeth. These are the edentulous areas, bilateral, right side and left side, class 1. Then you have class 2 situation, in which you have unilateral edentulous area located posterior to remaining natural teeth. Class 3 is unilateral edentulous area with natural teeth both anterior and posterior to it. And class 4 situation, it is single bilateral edentulous area located anterior to remaining natural teeth. So these Kennedy's classification formed a very good basis until people started facing major problems. What problems they were facing? Lacking physiologic aspect of prosthodontics, missing number, how many teeth are missing was not considered. Position and condition of the abutment teeth were not specified. And then the order was confusing. Relative location of modification spaces. We'll see what is modification spaces. But what happens is, challenging is, when multiple alternate teeth are missing and many conditions, Kennedy's couldn't specify it. So suppose now only one teeth is remaining in the arch. So you cannot classify whether it is in class 1, 2, 3 or 4. It becomes much difficult. So in order to overcome drawbacks of this, Applegate first he gave 2 class 5 and class 6. He took the class 3 Kennedy's relation, in which natural teeth are present both anteriorly and posteriorly. He said class 5 is an edentulous area bounded anterior and posterior by natural teeth. But the anterior teeth, which is the abutment, it is not suitable for support. That is class 5 situation. And class 6 situation, both anterior and posterior abutment are strong. These are known as Kennedy's Applegate class 5 and class 6. Important 8 Applegate rule for applying Kennedy's classification. Rule number 1, it says classification should follow rather than precede any extraction of teeth that might alter the original classification. Suppose now patient 6 is missing, 7 is missing. Okay, this is the condition. Now suppose 8 is grossly destructed and you are planning for an extraction. If you classify now at the present situation, it will become a class 3 situation because third molar is there and first and second molar are missing, premolars are there. Now if I extract the third molar teeth, then the situation from class 3 converts into class 2. So you are supposed to classify that now as a class 2 situation. Okay, so that is rule 1. Rule 2, if a third molar is missing and not to be replaced, it is not considered in classification. Rule number 3, if the third molar is present and is to be used as an abutment, it is considered in classification. Rule 4, if second molar is missing and it is not to be replaced, it is not considered in the classification. When suppose in opposing tooth there is no second molar and you are not planning to replace, then don't consider in classification. 5th rule, posterior most edentulous area always determine the classification. I give an example. 6, 7, 8 are missing on the left side and a central incisor is missing. Now you will get confused whether to classify this as class 2 or a class 3 situation. So Applegate gave a rule, the posterior most edentulous area, that is the class 2 situation here, will become the prime classification. Edentulous area other than those determining the classification are referred to as modification and are designated by their numbers. The extent of modification is not considered, only the number of additional edentulous area. So if whether in the modification spaces, whether 1 teeth is missing, 3 teeth is missing, it's not considered. It will be called as mod 1. Suppose some more teeth are missing, mod 2, mod 3, something like that. And rule 8 says there can be no modification areas in class 4 arches. So why? Because any missing tooth posterior to those class 4 area will become the primary classification. Okay. Hope these are clear. If not, again rewind back the video and again go through all these rules. Now these are the common types of denture what you do in your BDS program. But what is recommended is an cast partial denture which are having specific component, which are having specific principles. These are just a transition prosthesis which are conventional RPDs. Now what are the components of a removable prosthesis? That is cast partial denture. You have something called as major connectors. We'll go into details of each of them. Major connectors, you have certain minor connectors, you have direct retainers, you have indirect retainers, you have rest seat, you have denture base, and you have replacement teeth. So let's look into each of them. So this is a cast partial lower framework. So in this the components such as denture base and teeth are not there, but rest of the 7 components you can see in this picture. Now let's come to major connectors, the first component of it. So these major connectors connect the parts of the prosthesis located on one side of the arch to those on opposite side. This is one side of the arch, this is other side of the arch. They are connected by a major connector. So this is the major connector. One side of the arch to the other side of the arch, this is the major connector. Okay. So there are different types of major connectors. It could be a single posterior palatal bar, a palatal strap, closed horseshoe or antero-posterior palatal strap, antero-posterior or double palatal bar, complete palate coverage, horseshoe or U-shaped connector. So this is an example of a palatal bar. These are the least preferred ones, can be used in Kennedy's class 3 situation. This is a palatal strap. It is used primarily in Kennedy's class 3 situation. So you need to have a minimum 8 to 10 millimeter width of the strap. These are the most frequent type and most versatile type of major connector called as antero-posterior palatal strap. These can be used in all the type of situation, class 1, 2, 3, 4 situation. You have antero-posterior palatal bars. You have complete palatal coverage. Okay. The palatal plate connector indicated in class 1 arch forms only when there is anterior teeth or some premolar are present. These abutment teeth which are there, they are periodontally weak. So this will also provide indirect retention. Okay. Then you have horseshoe shape, use of full palatal coverage. Now this palatal portion is cut, that becomes an open end horseshoe shape. Whenever there are large tori or patient has an hyper gag reflex, then you can use this type of major connectors. Now we move on to mandibular major connectors. 4 types: lingual bar, lingual plate, double lingual bar and labial bar connector. So this is the first type, lingual bar connector. It is indicated whenever there is a presence of high floor of the mouth, extreme lingual tilt of anterior teeth or inoperable lingual tori, excluding this. A lingual plate connector, again this is most versatile use connector type of connector. It consists of a lingual bar plus a metal plate extending superiorly above the cingula but not higher than the middle third of the teeth. The superior border must be scalloped, okay, so that it extend into the interproximal area and patient will feel a little more natural. Indications, so these have got a plenty of indication. Whenever periodontally weak teeth are there, indirect retention is required. That time, in presence of inoperable lingual tori are there, when mandibular natural anterior teeth may need to be replaced in near future, you can use it. And this is an double lingual bar, also called as Kennedy's double lingual bar. The double lingual bar is composed of an conventional lingual bar and a second narrower bar located between the cingula inferiorly and the contact point superiorly. Okay. Another which you should know is the labial bar major connector. This is the labial bar major connector. This is selected when natural teeth are too much lingually inclined. Okay. Recontouring, orthodontic treatment or restoration with crown may correct the problem, but when such treatment is impossible or impractical, a labial bar is used. This is anesthetic, a little food get lodged over there, it has its own problem.